The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and we're here with another edition of The Genuine Article. And I have the pleasure of being with Dr. Philippe Manouche, who is well known to everyone, I'm sure, the head of the cardiac surgery program at the Georges Pompidou Hospital in Paris. And we're discussing a paper that will be in a forthcoming issue of JACC that was published by Dr. Okada and colleagues from the University of Pittsburgh and Carnegie Mellon, where they discuss a new cell, a skeletal endothelial myoblast that has proven to be quite effective in the treatment of post-infarction condition. Philippe, can you tell us a little bit about this study?
The study is interesting because the myoblast population is known to be quite heterogeneous. And the objective of the authors has been to figure out whether among these myogenic cells there was a definite subpopulation that could be better suited for cardiac repair. And actually they found, by using a combination of markers, that there was a subpopulation expressing both myogenic and endothelial markers, in which, in a head-to-head comparison with infractionated myoblasts in a rodent model of myocardial infarction, turned out to be more effective on the basis of the usual endpoints: function, fibrosis, angiogenesis, apoptosis, and so on. So it's an interesting attempt to fine-tune our selection of cells and to try to pick up those which might be more effective for improving post-infarct function.
Well, previous studies, the MAGIC trial being one of them, using skeletal myoblasts, have really been a bit disappointing, I would say, in terms of efficacy. Do you think this new myogenic endothelial cell could overcome some of the limitations of the previous cells?
Possibly. I think that part of the disappointing results of the MAGIC trial, which, by the way, has taught us a lot of things, was due to the fact that we may have not used the appropriate myogenic cells by using the infractionated bulk, and they tried to address this issue by picking up more specific cells. And also, I think there is a major problem with, regardless of the cell type, with these intraoperative injections. Injection per se may not be the most effective way of delivering the cells to the myocardium, because it's a technique which does not allow a very accurate control about the distribution of cells, because it causes disruption of cells at the time of injections, which probably increases the death rate of the cells. And also because with these multiple injections you create intramyocardial clusters which, regardless of the phenotype of the cells, can be and have been shown to be arrhythmogenic. And although myoblasts by themselves could be arrhythmogenic, I think other factors could come in play which have nothing to do with the cell themselves. Unfortunately, this particular issue of arrhythmia is not addressed in this paper, but anyway, the model itself is probably not the most appropriate for looking at these kind of endpoints. So.
Yeah. Well, dealing with the Okada paper, immediately we know that this is a study done in mice, infarction in mice, and so the extrapolation to humans is a bit more difficult. And these were immunosuppressed mice, and most of our patients, at least going in, are going to be immunologically competent, and that's a major challenge to the survival of cells. So I guess those are a couple of important issues in trying to determine how these findings can be translated to the human.
Yes, with the caveat that in this particular study, which extends actually their previous works, they have been able to isolate this population from human muscle, which means that if you're thinking in terms of clinical translation, you could imagine that instead of taking the muscular biopsy and just processing it the usual way, as we have done, you could isolate this particular population and give it back to the patient and thus overcome the immune problem.
I guess, in addition, we have to say that although they demonstrated that there was clearly an improvement of function, there was less apoptosis, that in fact there was better engraftment, that still the cells did not really regenerate myocytes, and this was still likely a paracrine effect.
Absolutely. This is probably the major limitation, which is clearly acknowledged in the manuscript, that these cells acted paracrinally but were unable to convert into new cardiomyocytes. So I think that if we are really targeting myocardial regeneration, generation of new donor-derived cardiomyocytes, we probably have to think of other cell types.
Well, no question, a step forward with this new cell showing some endocardial angiogenic possibilities as well as improving myogenic function, and we'll keep watching for the day when we actually are able to regenerate myocardium. Thanks very much.
Thank you very much.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.